Hello, my name is Kelly Kamimura Nishimura. I'm a developmental behavioral pediatrician at Cincinnati Children's Hospital. I will be presenting the findings of our study on behalf of our team. It is well known that many very important outcomes can be improved for individuals with ADHD if they receive and consistently get treatment. Therefore, our overall goal is to identify predictors of starting and continuing ADHD treatment so we know who is not getting treatment and who needs to be targeted for interventions to improve treatment received. The objective of the study is to investigate the sociodemographic, clinical, and parental attitudinal predictors of medication continuity in the first year after ADHD diagnosis. This study had two aims. For aim one, we investigated predictors of having at least one field ADHD prescription. And for aim two, amongst those with at least one field ADHD prescription, we wanted to investigate predictors of having more days covered with medication. Our participants included 144 stimulant-naive children with ADHD diagnosis who completed a methylphenidate trial. After the trial, they returned to their community primary care doctor, and we collected the pharmacy data 1 year after completing the trial. Our primary outcome was the number of days covered with the stimulant medication measured by the number of filled prescriptions over the first 12 months of treatment after leaving the clinical trial. We collected sociodemographic predictors as well as patient level and caregiver level predictors, including parental beliefs and perceptions about ADHD and its medications and perceptions of working alliance with a treating clinician. So we found that 84% of the children had at least 1 day of medication coverage, and participants had a mean of 170 days covered with medicine in the first year of treatment. Here are our results for aim one. After conducting bivariate analysis, we found that all of these factors listed here, things like non-white race, measure of family financial strain, higher belief that medication is harmful, and a perceived weaker alliance with the clinician, predicted not having any ADHD medication prescription filled. But when we conducted multivariable models, only having a perceived weaker working alliance with the first clinician who worked with the families on ADHD care remained a significant predictor of not filling any ADHD prescriptions. This shows the power of family-clinician relationship and also illustrates the importance of considering and accounting for the fullest possible range of potential factors. For aim two, we then look at just at those who had at least one ADHD medication prescription filled to see in this group what predicted having more prescriptions filled and therefore more days covered with medication. For this analysis in multivariable models, we found that non-white race, older age, female gender, lower income, lower belief that ADHD affects their life, and higher belief that medication is harmful predicted having fewer ADHD prescriptions filled, and having a comorbid ODD and a caregiver with an ADHD diagnosis predicted having more ADHD prescriptions filled. Some reasons for racial and ethnic disparities include uncertainties about medication efficacy and side effects, and in non-white groups, reduced access to mental health services and distrust of the healthcare system. The gender disparity in ADHD treatment observed in our study may be explained by externalizing behaviors being a strong predictor of ADHD medication use, and girls typically presented with fewer disruptive behaviors compared to boys. The decreased medication use among low-income families may be explained by barriers such as limited transportation and lack of available providers on pharmacy in their communities. The associations between lower parent belief that a child's ADHD affects their life and higher parent belief that medication is harmful and decreased ADHD medication coverage have been described in previous studies. For example, parents who view their child's difficulties as a medical disorder that requires a biological intervention are more likely to accept and continue medication. Similarly, parents who perceive ADHD medication as safe, effective, and socially acceptable are more likely to continue their children's treatment. In our study, Having comorbid ODD predicted ADHD medication continuity. This may be because having comorbid ODD is associated with worsening impairments and overall prognosis, possibly leading to parental persistence in seeking treatment and therefore prolonging their treatment courses. In conclusion, we found that the factors linked to decreased likelihood of starting and continuing taking ADHD medication include, for example, non-white race, having financial strain, perception that medication is harmful, and having weaker working alliance with clinicians. And an important next step will be to develop strategies to improve ADHD medication received and continuity when appropriate. Thank you very much.